Welcome to our telebriefing today. My name is Sharon Bogan, and I am a communications specialist here at Public Health Seattle and King County. And thank you all for joining, both reporters today and those of you who are tuning in via our Facebook live stream. We appreciate you joining us today as we talk about King County Public Health's contact tracing and case investigation efforts that have been going on for several months here at Public Health. So for news media, I'd like to let you know that you'll be able to ask questions after our speakers are done providing their comments, and you can do that via the raise hand function in Zoom. And then I will call on you to ask your questions during the Q&A section. So today with us, we have Dennis Worsham, who is the Prevention Division Director here at Public Health Seattle and King County. And we also have Dr. Matthew Golden, who is our medical lead for the case investigation team at Public Health Seattle and King County. He is also professor of medicine at University of Washington. So with that, I'd like to turn it over to Dennis Worsham for an overview of our efforts today.
All right, well, welcome. We're glad you joined us. We think there's been a lot of conversations around case and contact tracing, and we thought it would be good to provide some background about what's happening here in King County and maybe even historically a little bit about case and contact tracing. Majority of the programs that sit within my division are really about infectious diseases, and from a public health perspective, our primary role is to really interrupt and to be able to prevent or interrupt the transmission of disease within our communities. So a body of work that we've done for a long period of time in how we approach our work, and case and contact tracing is a major tool that we use in order to do that. Oftentimes what will happen is when we have reportable conditions within the state of Washington where we have certain diseases where they are mandated that both labs and clinics and providers are required to report. We get that information through a system called the Washington Disease Tracking, and we then follow up with some of these cases and do what we call a case interview to fully understand where people could have been exposed and who they may have exposed since they have been infected with this area. During the interview process, what we oftentimes will do is ask who else they may have been in contact with during that period of time. Those are oftentimes what we refer to as close contacts. So we then will do a follow-up interview with those close contacts as part of our work and reaching out to them and letting them know they've been exposed to a particular disease and what they need to do in order to either seek care or to be able to isolate or quarantine themselves from and not exposing other folks. As I mentioned before, this is something we do all the time in public health. We do it in our HIV work. We do it in our TB work. We do it in our measles. It's a practice that we've been doing for a long period of time in order to interrupt transmission within our communities. The thing that's a bit different here as COVID has been with us now for several months is we've just not seen anything quite to the same level of scale that we have seen come in with COVID. And so it has really caused a major challenge in our ability to respond quickly, get the right infrastructures in place in order to do the large magnitude of the response that is needed with this particular one and to ramp up quickly. Oftentimes what you'll hear in public health, we talk about our mitigation strategies or we talk about our containment strategies. At the beginning of COVID outbreak, the intent was really to contain the spread of the disease as much as we could and really trying to do case and contact tracing with individuals and places of business or places that they could have been exposed and to do that as fast as we could. Well, numbers came in so quickly and an infectious period, the number of infections in the community rose so quickly, we had to quickly shift our strategy and kind of do a combination of the two, doing what containment we could, but primarily focusing on where outbreaks and clusters were happening. You all know from our experience here in King County being hit first in the country, was hit very hard within a long-term care setting. And so we saw that spread very quickly within those environments. And so quickly moved from individual case contact investigations to really shifting mostly to outbreaks, clusters, and environments where congregate settings are or where people were being exposed. In about mid-March, we knew that we needed to do both as best we could. So King County took the priority with our facilities and congregate settings here to put our investigations teams to work and do that body of work, and asked the Department of Health statewide to help us really with our case and contacts and follow up where they could with that. And primarily the state took on contact tracing, case investigations as part of that work in March. As we're at a different place in the investigation now, we continue our investigations both with businesses, with congregate settings and places where we see exposure in different environments with investigations. But we have been ramping up our efforts here is to bring the case and contact tracing back in-house and doing that work. Dr. Matthew Golden will be speaking a little bit more about what our pilot project has been, where we're at in our process, and how we will be shifting our work more here in King County to doing both these particular bodies of function.
Great, thanks so much. I'll go ahead and turn it over now to you, Dr. Golden, for some more details.
Great. Well, good afternoon. Thanks for the opportunity to speak with you. What I'd like to do is give you a little background about what we've been doing and where we stand with contact tracing in King County, what we've learned in our initial experience and where we're going. As Dennis mentioned, on April 23rd, we began a pilot project of contact tracing in King County, which the objective of which was to establish effective case and contact investigation procedures and to estimate what we were going to need to bring this intervention to scale to affect all people who were infected with COVID-19. We have three goals with our case and contact investigation and tracing. The first is to identify people who are in need of medical services and ensure that they get the medical services that they need. The second is really the contact tracing, which has two components. We want to identify the contacts of cases who are potentially infected. These are the people they live with, the people they work with, other people with whom they have been in close contact. We also want to identify the venues where transmission may be occurring for outreach investigation. So potentially the places where people work and other places where transmission may be occurring and where there is an opportunity to intervene. And finally, we want to promote isolation and quarantine to avert ongoing transmission. So we need to identify who needs to be in isolation and quarantine, and then we need to help them be successful in staying in isolation and quarantine. To do this, we have organized three collaborative teams. The first is our contact tracing team. These are the people who are doing the interviews with the people who are infected with COVID-19, identifying who their contacts are, and identifying the venues where transmission may be occurring. The second is a social support services team. And this team is designed to help people be successful on INQ. So if you need groceries because you don't have them, so you can stay home, the team is able to help you with that. And we are developing what we hope is an expanding menu of social services to help people be successful with their isolation and quarantine. And finally, we have this outreach investigation team. When we identify a workplace where we think transmission is ongoing, so that we can do the outreach, investigate this, and see whether there are things we have to do to protect the public. Now, in terms of how this works, the laboratories report all positive results to COVID-19 to the State Health Department. The State Health Department and Public Health Seattle King County then work together to divide these cases up at present for which agency is going to investigate which cases. We then have a team of people who call the person who is infected with COVID-19 and they conduct an interview. And that interview asks them about their demographic characteristics, their medical history, what has been happening with them in terms of their health, their possible sources of exposure, who are their contacts. And all of this is confidential information. This is not something we release to the public. This is something which stays within the health department. We then provide people guidance on what do they need to do to stay in isolation or quarantine. And we try to assess, do they have medical or social service needs that we can help them with. So in terms of our progress to date, we have developed trainings and have begun to develop the staff we need to accomplish this objective. At present, we have 28 contact tracers, plus an additional 4 contact tracing leads. This includes 7 people who are still in training in that total of 28. 12 of our contact tracers speak Spanish, are bilingual, so we have capacity to reach the population which is being affected. At present, this represents about 18.5 full-time people working on this project. We anticipate adding 5 to 6 new trainees next week. And the week of July 6th, we will have an additional 10 people we expect to be trained. So we really have a growing team, and we believe that we will have a growing capacity to accelerate our training as we develop a cadre of veteran contact tracers who can help train their peers. The rate limiting step in developing the team is the capacity to provide the one-on-one training that people need. It isn't enough for people to watch a video on the internet. They really need that practical training, which is more labor intensive. We have developed a local database in collaboration with the state. So none of the activities we are doing are managed on paper and pencil. Everything is going into an electronic database and is consequently analyzable. Since the 26th of April, we have been standing this thing up. I think that we've learned quite a bit. We have had some successes and we've identified some challenges. So the proportion of cases that are now being managed by the King County team went from 10% in late April when we started to 71% over the last 2 weeks. We've done 1,075 interviews to date. So we have a growing staff and we have growing capacity. We have found 86% of the cases that we have sought, we have successfully interviewed. And 81% of the people we've interviewed them the same day we received the information about them. So we have been successful at reaching the cases, and we have been able to interview them quite quickly. Our cases are naming contacts. So that we have a median of 3.8 contacts named per index case. So most people are naming it at roughly an average of 4 people who are potential contacts. So I think those are all successes. We've also had some challenges. So although 90% of people say that they are in isolation when we contact them, only 21% of people went into isolation on the day they first developed symptoms. Over half of people are waiting to go into isolation until they test. But people on average are going about 3 days from the time that they develop symptoms to when they test. This is not really what we want. Only 39% of the contacts are testing. So we have embedded the testing into our efforts, but it needs to go to a higher scale. We are also developing follow-up procedures to contact people on a daily basis to ensure that they are successful with isolation. But that is only getting scaled up now, really only over the last week or so have we begun to institute. So what I would say is we are making progress in setting this up. We have rising numbers of people interviewing. We anticipate we will be able to manage all of the cases by the end of July on the Public Health Seattle King County team. We're successful at reaching the cases, and we're able to interview them quite quickly once we know about them. But we need to test people faster after symptoms, and we need to get the results faster so we can act on them. We really need people to go into isolation when they first develop the symptoms to mitigate the transmission of infection. This is a ship that we're building while we're sailing it. So flexibility is really key. I do not believe that anyone in the United States has a mature contact tracing program for COVID-19. Everybody is working to optimize the procedures as we develop. I think we also need to be realistic that contact tracing is not a panacea. It's one important component of a control program for COVID-19. It's important for all of us to realize we are not back to normal, and we all have a role to play in containing this pandemic. We're going to solve the problem by working together. But this is what we're asking of the public. If you develop symptoms, it is critical that you test right away and you go directly into isolation. It is important that we continue to socially distance. That means avoiding close contact with large groups of people, and particularly close contact indoors. We want people to continue to wear masks, and we want to limit gatherings to 5 people or less. So all of these are part of the phase 2 plan. So that's sort of a summary of what I have to say, but I'd be happy to try to answer questions if members of the press have them.
Wonderful. Thank you very much, Dr. Golden. And at this time, we'll take some questions from media. And to do that, you just need to raise your hand on the Zoom function, and I will unmute your line. So I'll give folks a moment. Yeah, Lindsay Sheldon, and if you can make sure to introduce yourself and your news agency, that will be helpful. Go ahead, Lindsay.
Thank you. This is Lindsay Sheldon over at Cairo 7 TV. I have a few questions. My first question was more of a general question for those of us who have not been following the contact tracing efforts throughout these months. Can you explain the impetus to try to bring contact tracing in these investigations back in-house to King County? I was under the impression, that the state was doing a lot of this. If you could kind of give us an understanding of this move to do more of this, and it sounds like all of it, hopefully, within King County by sometime in July. I'll ask that question first, and then I have a few follow-up questions based on what you guys were saying.
You want me to take care of this, Dennis?
Yeah, why don't you start?
So, I want to point out that we are very grateful for our collaboration with the state, and that they are critical to all of our success. I think there are some advantages to doing this locally. It's very important to tie this effort to the testing and to the provision of the support services I was mentioning, the things like the groceries. Those are all provided at the local level. So it really is easier, in a sense, for this to be managed by local public health than it is for it to be managed out of Olympia. So that's really how this has worked. I would also point out that traditionally, Public Health Seattle King County has done all of its own contact tracing for other infectious diseases. So it's a little unusual for us to rely on the State Department of Health for those activities.
Yeah, Lindsay, this is Dennis. Just a couple things I'd add to that. The way that we're structured in the public health system is it's a local jurisdiction that generally holds the responsibility for implementing public health practices. So it does fall back, and we are grateful during our ability to surge. We were so overwhelmed. We relied on our partners in the system of the state to really step in. And we also have great relationships with our healthcare providers here locally, as well as our businesses. And it's just when we do these case and contact investigations, and we do follow up with either healthcare settings or with businesses, it's here in our own backyard and have those relationships. So it seems to work the best that way for us.
Got it. So it's my understanding that during when this was on when it was increasing heavily, the state kind of took over, but you guys have been working to bring it back into house since late April. Is that correct?
That's correct. Yeah, we prioritized at the beginning of the responses where the clusters and outbreaks were happening in particular settings and environments, and to really put our energy and focus there while the state maintained reaching out to individuals that didn't have affiliations with those facilities. And as Dr. Golden mentioned, we've been, through our pilot project, bringing that back up and scaling up since April.
I think it's also important to mention that the intervention we're trying to institute is a more intensive intervention than what the state was going to be able to scale up, or what they were able to provide in that early phase of the epidemic. None of us had capacity to do the more intensive intervention in the first weeks or months of the epidemic.
When you say intervention, you mean this type of investigation and contact tracing?
Right, and the provision of the support services, and as we roll this out and it becomes more mature, the follow-up with people on a daily basis of at least some type to ensure their adherence with INQ, or with isolation and quarantine.
So is King County's team of contact tracers, is that within the Department of Health? Are there some volunteers? Are there National Guard members? How is it different from what we've heard from the state?
So this is all within public health. We are not relying on volunteers to do this. There are the cases that are being managed by the state. So as I mentioned, in the last 2 weeks, we've been managed 71% of the cases. The other cases that are managed by the state, some of them are interviewed by National Guard.
Gotcha. And you're moving to get all of the cases within King County managed by King County by sometime in July?
That's the goal. But we're collaborating with a lot of different people to staff this up. And part of this is that we want to make sure that this is a community-wide collaboration. There's a need to connect with a diverse population of people. We have to obviously speak the languages of the people who we're trying to communicate.
Can you go further into explaining the importance of handling or the benefits, I guess, of handling it on a county level when it comes to the contact tracing, but also helping people as they are recovering, like you mentioned, being able to facilitate getting them groceries, for example, or things like that? What are the specific benefits of handling it on a county level?
Well, I mean, I think the things we were saying that Dennis was saying. So where are they going to get tested, and who has the connections to the places they're going to get tested? How are we going to arrange for you to get the groceries? They're going to have to get the groceries from someone in Seattle. You know, we really have those resources, are more local resources, statewide resources.
Great.
Yeah, one of the things I'll just add to that as well, to Dr. Golden's comment. You know, we're constantly reviewing here in the health department about where testing is available, and open access testing in particular for people who don't have medical homes. And we're constantly responding to what the data tells us. And if we see geographically there are places that we need to assure that testing is available, we're able to do that here at a local level much more quickly and due to those relationships.
I think the other thing I just point out is that part of what we're trying to do is make sure we identify people who are really sick. And in those instances, when the contact tracers identify people who need medical follow-up, it's much easier for us to manage that locally, to figure out where are they going to go? Which clinic are they going to? Are they going to the ER? How is that all going to work?
Thank you, Lindsay, for those really great questions. Now we'd like to go to Kate Walters. Go ahead, Kate.
Hi, can you hear me? Can you guys hear me now?
We can, Kate.
All right, great. Thanks so much for taking the time to do this. Just wondering if you can address two questions for me. First of all, as we're seeing cases spike again, will you have the capacity to do all of the contact tracing needed in-house in King County? And then a second question specifically about the homeless population. How much more difficult does it become to implement contact tracing with folks who are experiencing homelessness, either in congregate settings or living unsheltered?
So in terms of as it spikes, will we be able to keep up with it? I suppose it depends on how much it spikes. So we're building the team as fast as we can, I would say. And to date, we are able to work the cases. But I don't have a crystal ball on that. So again, the contact tracing is part of a comprehensive effort to contain COVID-19. It is not in and of itself a complete solution. In terms of working with homeless populations, it is for sure much more difficult to provide contact tracing to a population that's living homeless. Part of the way to deal with this is that we have teams that are working in congregate settings directly, as opposed to trying to call people who do not have phones.
Yeah, this is Dennis. I'll just add one thing on the homeless piece. As Dr. Golden talked about, there's multiple approaches in how we are trying to contain and mitigate COVID. In the congregate settings, as I mentioned earlier, such as a homeless environment in shelters or other homeless settings, is we have established really quickly relationships with those shelter providers and working with both the city and the county who funds those and provides some oversight to those areas, is to build a pretty rapid team that we are able to get in and we do rapid testing, and we are able to do quick contact tracing in a different way in an environment versus a one-on-one that we do through the work that Dr. Golden is leading with the other team. So it's a whole team approach that jumps in an environment to really mitigate and to contain the spread of that within the areas of like in a homeless shelter or other environment.
Thank you so much. Just one follow-up question, if I could. Totally understand that you can't predict how big the spike is going to be. So at what point would it become too much for your team in terms of seeing the second wave? If it hit the same levels it did in the first wave for King County? Would that become problematic, or would it need to go higher for it to become an issue for your team?
You know, it depends on the rapidity with which it went up. So we can add 5 to 10 people at present, I think, per week. But I expect us to have an ability to accelerate our staffing, our training needs as time goes on, because we'll have a larger group of people to do the training. But it's really a question of, will the increase in the number of cases be faster than our ability to increase our capacity to train? We have two dynamics.
Yeah, I think the other thing I would add to what Dr. Golden has said is, first of all, we've got a huge candidate pool that we're trying to bring on. And as we've talked about, some of the challenges have been just getting the training happen, and the one-on-one training and the really life experience training that's important. And as those numbers increase on our team, we'll be able to do that in a more efficient way. We still also have the ability to work with the state to help surge if numbers get high, and to provide some backup, and also other local jurisdictions that may not be at the same level. But our infrastructure is much better now in order to scale up more rapidly than we were at the beginning of this response.
Great, thank you.
Thank you, Kate. Lindsay, did you have any follow-up questions? Additional?
I did, yeah, actually. I had a few. I wanted to check with Dr. Golden to make sure I understood some of the numbers that you were given in rapid succession there. You had mentioned something about 21%, I think, getting tested quickly, or once symptoms were shown. I was trying to write down all the different numbers. I'm hoping you can clarify that one, because you mentioned after that, you said this is not really what we want.
No, so the 21% is 21% of people are going into isolation the day they first develop symptoms. So in other words, you develop a fever or a cough. You continue to go out of your house? Or do you immediately say, wow, I bet I have to stay home? And only 21% of people stay home right away. Most people are waiting until they test. And that typically is happening about 3 days after the onset of symptoms. The problem is that people are typically infectious about 2 days prior to their onset of symptoms going forward. So if you spend 5 days on average, say, infectious and still going out, that's a problem. And we need to shorten that window where you're out in the public to potentially transmit.
And so would the recommendation in that situation be, as soon as you notice any symptoms, try to schedule testing and then isolate until you go to test? And obviously when you go to test, mask up. I mean, would those be the type of recommendation?
So we want you to test right away. And increasingly, it should be possible to test the same day. We really do have a growing capacity to do the tests. And then we need you to stay home.
And then sorry, go ahead.
Yeah, Dr. Golden, maybe you can speak a little bit also with those with symptoms, but also if you're a known contact. You may not have symptoms, but if you're a known contact, what the recommendation is.
Right. So for people who are, the distinction between isolation and quarantine is isolation is for people who are known to be infected with COVID-19. Quarantine refers to people who are contacts. If you are a contact to COVID-19, we are asking you to stay in quarantine for 14 days following your last contact with somebody who's infected, or if you're living with somebody, for 14 days after their period of isolation. So I know that's tough, and testing negative doesn't actually change that recommendation. But testing positive does tell us both how long you're going to have to stay in isolation and gives us an indication that there are other people that we may need to be thinking of.
And doctor, when you talked about 39% of contacts are tested, could you clarify what your thoughts are around that, and how many contacts you would like to see tested?
I would like to see all of them tested. So our recommendation is that if you are contacted with COVID-19, you should be tested. So we're really trying to ratchet that up. And I think as the testing capacity improves, and as we get this message out there, my hope is that we will see this number rise. Part of the challenge here is that if you think back even 4 weeks, our message to people very much was, if you're sick and you're not too bad, stay home, right? And you would call the clinic. I work in a clinic. And we would say, if you're doing okay, you don't necessarily get tested. We have 100% shifted now. Now we have the capacity to test the people. And our message is, at the first inkling of a symptom, you need to be tested.
Got it. So obviously you're advocating for that quarantining if you've been notified that you may have been in contact with someone, but also getting tested as a possible contact of somebody who has COVID-19. Okay. And my last question to you guys would be just if you could, obviously it is not, like you said, the panacea, but it's not the panacea, I'm sorry. But it's something that's a huge part of preventing a greater surge. Today, we were looking at some of these states like Texas and other places who are slowing down their reopening due to these surges. And so I'm wondering for our viewers, if you can kind of emphasize the importance of this contact tracing and, responding to these phone calls and acting on this advice that you're receiving. If you could emphasize that for us, that'd be really helpful.
Yeah, well, the contact tracing can't work if the public doesn't cooperate. So we're all going to have to work together to control this problem. What I'm encouraged by is mostly people are pretty open to this. As I said, we are able to interview the vast majority of people. We're able to interview them very quickly. I think people get it. And so we just really need to reinforce that message. We are working effectively together, and we're building this together.
That this, in concert with the social distancing and the masking and things like that, can help prevent that surge once again.
Right. The contact tracing is one piece of a comprehensive program to control COVID-19.
Thank you, guys. I really appreciate it.
Thank you. We're getting some questions from folks who are viewing via our Facebook page, and I just wanted to share a few of them with you both. What about folks who may be undocumented? Are services available? How is that working? And as well, if you can comment a little bit about connection with testing and how that might work.
Right. Good question. So testing is available to everyone, regardless of whether or not they are documented or not documented. And I want to emphasize that the contact tracing process is a confidential process. This will not affect anybody's legal status in the United States. And we really need to be successful with all communities, and particularly with Hispanic communities, which have been disproportionately impacted by COVID-19. So it's really an important point. So thank you for raising that.
Yeah, and just to follow up, Dennis, if you could share a little bit more about access to testing in the community for folks who may not have a provider that they normally seek care from, just to share a little bit more about where folks can go and what our approach is on that. That would be helpful.
Yeah, absolutely. So we have, we're working really closely with a lot of our community health providers, our community clinics, in providing what we call open access testing, meaning that you don't have to be a registered patient there in order to go get tested. Maybe Sharon or somebody can put out on the chat is we have a PIC line here, which is really a public telephone number that people can call and ask questions or seek additional information. Because those places are increasingly, as Dr. Golden said, we're getting more and more people stepping forward, wanting to help in providing open access testing, is we can give you a current list of who those are based in your geographic location of where you're at. But we do have a number of identified that we're helping to support, provide supplies to, and funding to be able to provide this open access testing. So doesn't matter if you're documented or not, if they're your health home or not, it's most important. We're trying to remove all barriers we can for people to get tested.
Look, I just entered on the chat the website that you can go to find a list of places to be tested if you need to get a free or very low cost test. So,
Great. And a question from the public, as we've all heard, there's been an increasing number of folks that we brought on board to serve these roles as contact tracers. Someone's wondering about how to become a contact tracer. And at this point, we're all public professionals. It's a great field as a contact tracer and beyond. But if one of you could talk a little bit more about the process for getting any kind of certification or being able to be in some of those roles, that would be great.
Yeah, we do have these posted right now on our public health website. You can go there and look. I will tell you, we have over 1,400 applicants currently. So we've had a great response, our largest recruitment we've ever done in public health. Very minimum qualifications, and the training is on the job. And we are really trying to be diligent as best we can to really get a diverse staff that really represents the community in which we're serving. And there's been a high level of commitment to that. But you can get on, see the job posting on our public health website and apply there if you are at all interested.
Wonderful, great. And let's see if there's any more questions from the reporters on the line, and then we can take one more question from the public. So I'll just give it a moment. There's a question here about the nature of the fact that COVID-19 can spread and you can have no symptoms, asymptomatic folks. So I think this is a question about what are we doing around asymptomatic folks who may have COVID-19. And I think it speaks back to Dr. Golden's point that even if you aren't symptomatic, that through this contact tracing approach, we can identify folks and get them to get tested even without symptoms. So just wanted to reinforce that. But Dr. Golden, if you want to talk a little bit more about that, it sounds like that'd be of interest to the public.
Yeah, well, it's a good question. So roughly 15% of people with COVID-19 will not develop symptoms, or their symptoms will be so mild that they won't identify them as anything. Additionally, most people are transmissible before they develop symptoms. So this represents a problem as well. One of the advantages of contact tracing is that it is a mechanism for identifying asymptomatic infection. Screening in general is unlikely to be super successful for COVID-19 because the duration of infection is relatively short, and the overall prevalence in the population at any moment in time is low. So it would need to be very carefully directed. But contact tracing should identify people with asymptomatic infections, which is part of the reason what we really need to do to be successful here is we need to identify a much larger proportion of the symptomatic infections through testing and then follow up on all of those people, which will lead us to those asymptomatic and pre-symptomatic infections.
Thank you for that explanation. So I want to turn it back over just for any final comments from Dennis or Dr. Golden, and then we'll conclude.
Yeah, I can definitely start and then hand it over to Dr. Golden. I think that the thing I'd want to reemphasize just in the general message about COVID-19 and where we're at is that it's a multi-pronged approach, and we have to be in partnership with our community in order to be successful. So really maintaining the social distancing, continue to wear masks when you're in places where you can't be within 6 feet. To maintain that social distancing piece, to wear a mask for sure, to get tested, to stay home if you're sick, to not participate in events, family or community or work if you do have symptoms, that those are going to be important personal responsibilities in order to be able to really combat this virus and where we're at right now without really having a vaccine and effective treatment available to us.
I think that's a good summary, Dennis.
Great. Well, thank you to our media partners who are working hard to cover this issue for the public. There's a lot of changes, and so we really appreciate you joining us, sharing this important information with your viewers and listeners, and to the public who've joined us today. With that, we'll conclude.
Thank you.
Thank you.
Thank you.